Hello, everyone. I'm Dr. Keagan Lee, one of the co-founders at Sagis Diagnostics. Welcome to week 12 of our happy hour, Dermpath happy hour sessions. Wanted to just welcome some of the, anybody that's new who's just starting the first years. If this is your first time, welcome. Please check us out on our YouTube channel. You can go to our website here, which I have up on the screen. You can go to sagisdx.com and click on the education tab, and it'll take you to where you can register for some of our board review exam. If you already took that and want to review that and need the password for the test and the videos, just let us know. But anyway, you can check out all of our past sessions on YouTube with our links here. And also, please subscribe to our YouTube channel, and it'll let you know whenever we have new videos up. We know some of you are taking the core exams here in the next couple of weeks, so these are good sessions to review before you take that exam. And in the next couple weeks, in the next coming weeks, we'll have some special guest lectures as well. So please stay tuned for that. It should be a lot of fun. And with that, let's go ahead and get started. Okay, this is our first case. And as you can see, we've got a punch biopsy or maybe even excisional biopsy with the epidermis at the top and the subcutaneous fat down in the bottom. And then we have a dermal nodule. And if you zoom in here, you start to see that it's pretty dense here in the center, and then it kind of peters out here at the edges where it wraps around collagen bundles. So you can see these large pink collagen bundles. We call those ropey collagen bundles or keloidal collagen bundles. And so you've got this dermal proliferation. And if we zoom in even further, we start to see that the cells are spindled. Some of them are multinucleated. You can see here, multinucleated cell. Some of them have lipid or foamy, like this one here. And over here, these as well. Some foamy cells. Okay, and this lets you know that these cells are likely histiocytic in nature. Okay, so if we zoom out a little bit more, this wrapping around at the edges kind of hints to what this is. If you look at the overlying epidermis, overlying this proliferation, it is slightly hyperplastic, and it's even hyperpigmented. You guys can see this these pigmented areas down at in the basal layer. Okay. And if we zoom out a little bit more, it does go a little bit into the underlying fat, but it doesn't go really deep. It just kind of goes very superficially and involves the overlying fat. So it doesn't invade deep into the fat. So this is a dermatofibroma. And it's quite cellular, so someone might characterize this as a cellular dermatofibroma. And in dermatofibromas, you can start to get foamy cells. You can get some with hemosiderin in the histiocytes. These are basically fibrous histiocytes. They are at the edges creating this, and even within the lesion, creating these thickened collagen bundles. Okay, they are like fibrous in nature as well. So if you look around, you may see a couple of mitotic figures. You shouldn't worry about that. You shouldn't really see zones of necrosis. And the cells can be of varying size. They can be multinucleated, as we've already pointed out. So those are not reasons to be alarmed. You should not see really large pleomorphic cells in them, but every once in a while you do. But if you look around, those should be more rare. And in those cases, we call it a dermatofibroma with bizarre or monster cells. This one doesn't really have any in it. But this is kind of your run-of-the-mill dermatofibroma. As this one is a nice example because they can go quite deep and they can kind of extend into the superficial fat. But again, they should not invade very deep. If they do, you start thinking of something malignant. Okay. Let's go to the next case. All right. Here we have a nice punch biopsy. As you can see, it's nice sharp edges at the end, on the edge of it here. Nice sharp straight edges. It does pucker a little bit at the top. Okay, so that lets you know this is quite fibrotic. And if we notice that the adnexal structures are preserved here. If we zoom in, you actually see these horizontal spindle cells going in these horizontal fascicles. And they are parallel to the epidermis. You can see that here. So they're going horizontal here, parallel to the overlying epidermis. The cytoplasm is quite pink, okay? But the nuclei are small, spindled, kind of wavy, okay? And they taper at the edge. But notice how pink this cytoplasm is. It's really this horizontal pattern that clues you into what this is. This is a dermatomyofibroma. So somewhat related to the dermatofibroma, except in this case, the cells actually have a smooth muscle aspect to them. It's benign, okay, and it again should not invade deep into the subcutaneous fat. So this one is mostly in the dermis. And these will stain for smooth muscle actin. And hence that's where they get their name dermatomyofibroma. Okay. Go to the next case. All right. This one's a little bit different from the previous two. Again, we have a proliferation here in the dermis, but notice how it's going down into the subcutaneous fat. Okay, and actually it's wrapping around individual adipocytes. It's quite deep. Okay, and if we zoom in again, these are small spindle cells. If you look around, they're not particularly pleomorphic. We don't have areas of necrosis, okay? But in this case, they are going deep into the subcutaneous fat, and that's what clues you into what this is. This is a dermatofibrosarcoma protuberans, or DFSP, and DFSP is kind of interesting because unlike what you normally would think in a malignant neoplasm, the cells are actually quite monomorphous and not pleomorphic. Okay, the nuclei are quite small, but look how cellular this is. That's one of the clues, and it's actually the monomorphic nature of the infiltrate that clues you into DFSP versus a dermatofibroma where the cells are actually varying they have quite a bit of variation in size. Notice this one does, at the edges, they do wrap around collagen bundles as well, okay? They are somewhat related to DFs, but in this case, they are going deep into the fat, okay? You don't always see the fat in a biopsy, but just look. And even at the surface of this lesion, you can see that it's involving the fat quite extensively. Okay. Again, so you're looking at the monomorphous nature of the cells, and then it's going down into the fat. This one is actually quite deep. They can go closer up to the epidermis as well. This one's actually starting way deep and going even deeper down into the subcutaneous fat. If you're at all uncertain to what it is, of course, you can do stains. These are strongly CD34 positive. they should be Desmond negative. The CD34 is going to be your stain that lets you know what this is. Okay, next case. All right, so this one has a similar appearance to the previous one. Let me see if I can actually darken it a little bit because this is a little bit faded here. Bear with me. Try to darken this just a little bit. Okay, hopefully we can see this one. So you actually have a little bit of epidermis here. And then you have this infiltrate that's kind of in the fat, or it appears to be in the fat. So this is actually probably some normal fat, and then this is fat within the lesion. Okay, if we zoom in to see what this infiltrate is, again, it is small spindle cells with abundant collagen. And then they are kind of going around these fat cells. Now, in this case, the history is going to help you quite a bit. These are seen often in infants, young kids under 2 years of age, in the axilla or groin areas usually, and they'll be big, hard, rubbery nodules. And this is a fibrous hamartoma of infancy. And in this case, the fat is actually part of the lesion. This is a hamartoma. Okay, so it's not a true neoplasm. It's just having cells growing where they shouldn't grow, but they should not continue to grow over time. This one actually, the fat is part of the lesion, so the fat cells are just actually growing within this lesion. It's not really wrapping around the fat. At the edge, you can kind of see the normal fat. Okay, so it is pushing on the normal fat, but right next to it here, these fat lobules are actually just part of the hamartoma. Okay, you can actually see that within the lesion as well, you have some of the eccrine and apocrine ducts here, the sweat glands. Okay, but again, should be monomorphous. You shouldn't see the cells should be really hard to see because they're so small. So you have to zoom in to see the cells. There shouldn't be mitotic figures, and the history would help quite a bit on this. But this is a fibrous hamartoma of infancy. You can see these in older patients as occasionally, but usually under 2 years of age. All right, next case. When you look around here, you don't see epidermis, your dermis as well. So we're mostly in the subcutaneous fat. Again, you can see the fat here. And you have this nodular proliferation, somewhat circumscribed. Okay. And if we zoom in to see what the proliferation is, again, you're starting to notice a theme here: spindle cells. Okay, a lot of collagen bundles. So a lot of thickened fibrotic collagen. And in some areas, there's this mixed appearance to the cytoplasm cells. Okay, when you have this proliferation of spindle cells, kind of going in different directions along with this myxoid pattern, we call this a tissue culture-like pattern, because when you grow cells in a tissue culture, this is what they actually look like. If we go around again, in other areas, it can be more fibrotic in some areas, but relatively well circumscribed. Business change. Traditionally see areas of necrosis, and anywhere you look, you do get this fibrosis within the lesion. Oh, let's see if I can get this. So this is nodular fasciitis. And again, it is this kind of mucinous appearance to the cells in this story-form pattern that clues you to this. Let's go look at some areas and you can see this. It was first thought that these were reactive in nature, secondary to trauma, but they've seen this happen in areas where there isn't any trauma. And they have found mutations in these lesions. So I actually do think now these are neoplastic. But they are benign. They can resolve on their own, as can many of the benign fibrohistiocytic lesions or fibrohistiocytic tumors. But this is nodular fasciitis. If you're wondering what all these little tiny areas, these little tiny slit-like areas are, those are just blood vessels within the lesion. But again, you see this thickened collagen, so it is like a fibrous fibrohistiocytic lesion. Okay. If you were at all worried about this, you could do some stains. These will be SMA positive, as many of the fibrohistiocytic lesions are, but they should be negative for markers of other spindle cell neoplasms like S100, which you would see in neural lesions. CD34 will be negative if you're thinking this is DFSP. Desmond will be negative. These are not smooth muscle tumors, but they often are smooth muscle actin positive, but Desmond negative. Okay. Next case. Okay. We have a shave. We have a little bit of epidermis here. And if you go to kind of the dermal epidermal junction, you can see the basement membrane, and then you see this proliferation underneath it. So this is probably not emanating off of the epidermis, although it's hard to tell because most of the epidermis is gone or ulcerated, which is not unusual in this lesion. And so when we go in to see what the proliferation is, again, spindle cells, you can see the collagen bundles, so quite fibrotic. And if you go in even further, you start to see some of these cells are a little bit larger and pleomorphic in size. Same with these over here. You can see some mitotic figures in this. Zoom in over here. And some of the cells are multinucleated. Again, look at, you see how large these cells are. This is maybe, look at this nuclei in relation to this one. So pleomorphic, different shapes, different sizes. Some of them are a little hyperchromatic, meaning they're darker. Okay, so this is an atypical fibroxanthoma. And one of the things you have to worry about with atypical fibroxanthomas is when you can't see the bottom of them, if they should be mostly in the dermis. If they start to invade deep into the fat, you start to think of a undifferentiated pleomorphic sarcoma. And those basically have the same histology. They look the same. It's just a matter of how deep they invade. They stain the same as well. So you can't distinguish them just by stain or a superficial shave. So in this case, you might call this one a probable atypical fibroxanthoma and just say, the differential would include an undifferentiated pleomorphic sarcoma. And that can only be really determined once you excise the lesion. But as with any spindle cell neoplasm, you're going to do stains, and this is going to be negative for just about everything except for maybe SMA and factor 13A. Should be CD34 negative, mostly S100 negative, pancytokeratin if you're thinking of a spindle cell squamous cell carcinoma, and you can also do some other stains that are not as specific, but CD99 will be positive in these. Let's see if I'm missing anything else. D240 can be positive in these. So really, once you determine that it's a spindle cell neoplasm, usually in older patients on sun-damaged skin, you want to just rule out everything. And once you've ruled out, you know, a melanocytic lesion or a carcinoma, or even a vascular tumor with CD31, and then you can show that it's SMA positive and factor 13A, you're confident that is a atypical fibroxanthoma. Okay. I'm just going to glance over at my chat here just to see if any questions. Nope. All right. Next case. Again, in this one, I don't see epidermis or dermis. We see some subcutaneous fat. So again, we are in the subcutaneous area, and you have this nodular lesion, well circumscribed, kind of bulbous proliferation here. And notice the color of this, pink and kind of purplish. This purplish hue to the lesion really clues you into what this is. You can have areas of necrosis within this lesion with calcification. The calcification comes after the areas of necrosis. And that's because this lesion tends to grow and it doesn't have a really good blood supply within it. You don't see a lot of vascular or blood vessels within the lesion. You see them at the edge, but not within the lesion. This is a myofibroma. And if you go in, it's not very cellular. You can see these small cells, and they're within this kind of chondroid stroma. They make up this chondroid kind of matrix between the cells. And so this lesion is going to be really hard and firm, but very well circumscribed. Kind of have some artifact here with some clefting, similar to what you see in like a basal cell carcinoma. But these cells are small, spindled, and they have this kind of bluish chondroid matrix that they produce. Again, don't be alarmed by the necrosis, which you often attribute to malignant. In this case, the lesion is not malignant, but can have some necrosis and some calcification. But myofibroma, you can stain this. They will be SMA positive, but they should be negative for S100, pancytokeratin, and desmin. So SMA positive. Myofibroma. Next case. Another subcutaneous lesion, very well circumscribed, nodular, similar to the previous one. But this one's a little more cellular. It's kind of faded here, but if we zoom in, you can see all these little nuclei. This is quite cellular, okay? And then if you look hard enough, you start to make out other cells. And these are multinucleated cells. And you can see how most of the nuclei are kind of around the periphery of the at one edge of the multinucleated cell, and the cells are can be scalloped in some areas. We call these osteoclast-like giant cells because these are what you see in bone marrow. They osteoclasts that help reform and eat up the bone and eat up old bone so that new bone can be made. But these are not osteoclasts, but they have the appearance of osteoclasts. So we call them osteoclast-like cells, just multinucleated cells. But those are kind of sprinkled in. Most of the cells are mononuclear, meaning they just have one nuclei. And then sprinkled in are these multinucleated giant cells. These lesions are well circumscribed. You can see that if we go around, well circumscribed. Let's go look in this area. Don't really have a lot of areas of necrosis, but we do have these thickened collagen bundles. So this is a fibrohistiocytic lesion. And this is a giant cell tumor of the tendon sheath. And every once in a while you can see the tendon. I don't know that I can see it here. but you can see these coming off of a tendon. I don't really see that a tendon here, but in these plane of sections. But they are well circumscribed lesion, and they have these characteristic osteoclast-like giant cells that gives them the name giant cell tumor. Giant cell tumor of the tendon sheath. If you were to stain these, the giant cells are CD68 positive. The mononuclear cells tend to be patchy Desmond positive, but SMA negative. These lesions can have mitotic figures within them. That does not make them malignant. And some of the histiocytes can be foamy. And you can really get those foamy xanthomatous changes in almost any fibrohistiocytic lesion. But these giant cells really clue you into what this is. Okay. And remember, well circumscribed. All right, next one. We have this kind of dome-shaped appearance to this biopsy. The epidermis is maybe a little bit hyperplastic, but then within the dermis, you have a proliferation of these small spindle cells. Again, this is has a fibrohistiocytic appearance to them. And I am going to try to adjust this a little bit here. You guys can do this yourselves when you're using the Path Presenter platform here, like I'm doing. Let's see if I can darken this just a little bit. And really, the history is going to help you in this lesion. But we're thinking this is a fibrohistiocytic lesion. You got these large blood vessels, so it almost looks like a fibrous papule. But we are not on the face. We are actually on the hand, or probably the hand or the foot. This is kind of reminiscent of acral skin. So wanted to zoom in here, and you can see red blood cells. These are red blood cells within small blood vessels and capillaries. But then you also start to see other pink globules that are not in blood vessels, and they're kind of lighter pink. They're not quite as red as the red blood cells, so they're a little more just light pinkish in color, but they're round. You see these little round inclusions? Okay, this is infantile digital fibromatosis. You see these in little kids, but you can also see these in adults. So they've changed the name to inclusion body fibromatosis because it doesn't just occur in infants. But kind of the same theme that we've been going on in benign, small spindle cells. You shouldn't see a lot of mitotic figures. You shouldn't see zones of necrosis. And really, you got to look around. The history would be helpful, but when you look around, you see these little pink inclusions, and those tell you what they are. Those will be SMA positive, those little pink inclusions. They are actin. That's what they consist of actin, these little inclusions. And then if you do an SMA stain, you will see what we call a tram track pattern, where you have positivity in these parallel rail-like pattern of the cells. Desmond will also be positive in these cells, so that kind of helps you, because Desmond is usually negative in a lot of the fibrohistiocytic lesions. So if you needed to stain this, you could do both SMA and Desmond, but really it's these little pink inclusions. And as you look around, you start to just see them all over the place. Okay. All right, next case. All right, let me zoom in over here. We have another kind of dome-shaped papular lesion here. The overlying epidermis looks relatively normal. and most of the action is going on in the dermis. You have these large dilated blood vessels, and then you have this proliferation of smaller round to spindled cells. And they're really spindled cells. A lot of them are coming right at you if you think of this in 3D, and when you cut them kind of, when they're coming at you perpendicular, they appear round. And this is quite cellular, but you have these dilated blood vessels. And again, the history will help you. This is on the face. And this is just a fibrous papule, but it's a variation of a fibrous papule. It's a hypercellular fibrous papule. And in fibrous papules, you can get a lot of different appearance to the fibrocytes. They can be cellular. They can, you can have foamy appearance to them, so they can be, they can have xanthomatous features. You can have a lot of multinucleated cells. So, and if you look around here, you can see a couple of multinucleated cells. So they really can have a variety of appearances, but at the end of the day, they're all just fibrous papules or angiofibromas. If you do see these in, particularly in young patients and have multiple lesions, you start to think of tuberous sclerosis or even Burt-Hogg-de-Bay. So just remember that some people say you can tell the difference, but really you can't. They all look the same. They all look like fibrous papules, so you can't really tell just from looking at the lesion that it's a angiofibroma of tuberous sclerosis. You really have to go by the clinical. But again, no mitotic figures, no necrosis. You can occasionally get pleomorphic cells within it, but those should be the minority of the population. It should be relatively small, somewhat circumscribed, and it should not go very deep. This one goes to the base of the specimen, so we don't know how deep it goes, but if you were to get under it, they should not go very deep. Okay. Next case. All right, this one is kind of a polypoid lesion. Just looking at it, you might think of it as just a skin tag. But if we actually go in, you can see it has relatively normal collagen. Some of the collagen bundles might be a little bit thickened. If we zoom in a little more, you start to see these dark cells. And they are somewhat spindled, enlarged. Some of them are small, some of them are much larger, but they're kind of well spaced out. This is not a very cellular lesion, so the cells are spaced out away from each other, and they're kind of just hanging out in between the collagen bundles. So this is a very subtle lesion, but it's these large pleomorphic cells that clue you up to what it is. This is a pleomorphic fibroma. So it's totally benign. The cells can look a little ugly. They're large. Some of them are small, though, if you look around, okay? So what catches your eye are the large cells, but if you look around, you see the small ones too. So they're pleomorphic. They're somewhat stellate shaped, okay, star shaped, or they have points to them. But again, they are well spaced out within this lesion, and so it's not very cellular, and that clues you into that this is likely benign, and this is a pleomorphic fibroma. Okay, just look how much space is in between a lot of these cells. All right, pleomorphic fibroma. They are also SMA positive, just like a lot of these fibrohistiocytic lesions. They are also CD34 positive, so that can help you if you did both stains, but they should be S100 negative. Okay. Someone asked, could this be TMEP? No, this is not TMEP. The cells are too pleomorphic, and these are not mast cells. Mast cells kind of have that fried egg appearance with granular cytoplasm. These are more tapered at the end, so more spindly or stellate shaped. So these are not mast cells. And if you were in doubt, you could stain them. These should not be c-KIT positive, and mast cells would not be CD34 or SMA positive. Okay, this is our last case of the day. This one is in the dermis, okay, a dermal nodule. The overlying epidermis looks relatively normal, maybe thinned in some areas where this nodular lesion is pressing up against it, stretching it out a little bit. Let's go ahead and zoom in. Really well circumscribed nodule here. And as we zoom in, the lesion is kind of, I'd say, moderately cellular. It's more cellular in some areas and hypocellular in other areas. But right off the bat, what should catch your eye are these little slit-like spaces. Okay, so you've got this this collagen, and in between the collagen bundles are these slit-like clear spaces. Okay, and then when you look at the cells themselves, they are small. Maybe a little bit spindled in some areas. They do have this kind of bluish cytoplasm to them, and occasionally you might have a multinucleated cell or two, but most of them are just mononuclear cells. But it's really this slit-like pattern to the collagen that should clue you to what this is. This is a sclerotic fibroma. Okay, and you will occasionally see this pattern focally within, usually in the center of a dermatofibroma. So some people think these are kind of burnt out dermatofibromas. I'm not so sure because they're so well circumscribed. I just think you kind of get this pattern focally sometimes in older dermatofibromas. But in any case, it's benign. It's a fibrohistiocytic lesion, and it's these slit-like spaces in between the collagen that clue you as to what this is. Someone asked, can you see this in DFSP? I haven't really seen it. I'm sure you can. Pretty much almost in any fibrohistiocytic lesion, I'm sure this is a fibrohistiocytic lesion. You can start to have overlapping features, and I'm sure you could see this pattern somewhat focally. But really, in DFSPs, they're cellular. You know, you might see focal acellular areas, but you wouldn't. In this case, the whole lesion, I don't really see a cellular area, so I wouldn't think DFSP. But to see this pattern focally within a DFSP, I'm sure you can. I'm sure it's been described. I haven't personally seen it, but that doesn't mean it can't happen. What's interesting when you bringing up the DFSP is that these are CD34 positive. So that does not mean it's a DFSP. So you just got to be careful. You're really going on the histology here of these slit-like spaces and the well circumscribed nature of this lesion. This is going kind of deep and probably pushing into the subcutaneous fat, but it's not invading. It's really well circumscribed. So it's not invading in these little like, I call them tongues of invasion or individual cells. It's really well circumscribed. You can see these in Cowden's syndrome, so that might be a board question. And as I mentioned, you can see this pattern focally within, I often see them within DFs, especially cellular DFs. Anyway, that is the last case for today. And if you guys do have let's see, I'm just going to check to see if there's any other questions. How do you tell this? How do you tell this from EED? Well, again, it's really well circumscribed, and you really want to show that this is fibrohistiocytic. And when you kind of look around here, well circumscribed. these little tiny fibrocytes. That's what clues you in that this is not EED. And then again, you can do the stains, but this one is going to be CD34 positive. If you need more, if you want some more detail on that, I'd be happy to email you. Just shoot us an email. My email, if anybody has any questions, it's klee@sagisdx.com, or you can send us an email to our general email at education@sagisdx.com. And again, please like us on YouTube and subscribe to our channel. And stick around for the next upcoming weeks. We'll have some guest lectures, and we hope to see you guys there. And thank you for joining us today. Hope you found this useful. Take care. Have a great day.